Okay, so we're going to switch gears a little bit. So I'm Bishop-Fitzpatrick. I'm an assistant professor in social work at UW-Madison, and I'm an affiliate in the Division of Geriatrics and Gerontology over at the med school and an investigator here at the Waisman Center. Something that I think is really interesting about the Waisman Center is the degree to which we get to know people from very different disciplinary backgrounds. So Doug and I shared an office during the Waisman T32 postdoc, and we've been in a writing group together for 3 years. So as a health services researcher, I typically don't learn a lot about brain development and neuroimaging, but because of the opportunities to socialize and collaborate interdisciplinarily here, I know quite a bit about it, and I've seen a lot of Doug's studies develop over time. So I think it's just a neat way to think about what we do at the Waisman Center and how it can improve our research here. So, and to talk first, I want to first say I don't have any conflicts of interest, but I have received and I've also been submitted by the Waisman Center T32 postdoc program and through the core grant of the Waisman Center. I also want to say before I get started that I will interchangeably use different terminology to refer to people on the autism spectrum. So I'll say people on the autism spectrum and I'll say autistic adults. There have been studies recently that have found that people on the autism spectrum or autistic adults prefer one of those terminologies. I know that people have different opinions about preferred terminology for autism. These are what I'm choosing to use. But when I answer questions at the end, I'll be sure to use the terminology that you all used in your questions when responding. So we're going to talk about aging in autism and developmental disabilities. So how did I get interested in this? So I've been working with people on the autism spectrum for 20 years. I started volunteering as a high school student. And I worked as a clinical social worker and as a health services researcher, and I've done agency-based research at nonprofits. When we think about aging with developmental disabilities, we have to think about the historical context. So in the past 30 years to 40 years, we've seen really widespread deinstitutionalization. So instead of people living away from their families in institutions, people are now living in the community with their families throughout their lives. We've seen that, I would like to think that we've seen really increased awareness and acceptance, and that we're doing a much better job than we were 20 to 30 years ago at integrating people with education settings into communities, into jobs, into our churches and social groups. And because of that, we also have seen increased access to care through federal programs like Medicaid and Medicare. I use data from both of these programs in my research, so it's important from a care and also research perspective. And then one really great thing is that we've seen drastically increased life expectancy. However, what that means is that we now have to figure out what happens to people with autism and other developmental disabilities when they hit midlife and old age, so that we can do a better job of supporting them throughout their lives. In the research that I'm presenting today, I'm going to be using a population approach. So what we're doing with this approach is that we're studying people on the autism spectrum, or autistic people, as a group. So we're looking at these big data sets where we're looking at groups of people who are de-identified, who I don't know anything about their identifying information, and we're comparing groups. And what this means is that these findings may not be true for everybody. Like Doug Dean presented in his slides, we see that some people on the autism spectrum are very similar to some people who are not on the autism spectrum. But as a group, we may see differences. So the means might be different, but individuals may not be affected. And what we're looking at is higher probability or greater likelihood of a risk based on being in one group compared to another group. In this presentation, I'll be talking about two comparisons, one in autistic people compared to people from the general population, and the other in autistic people with an intellectual disability compared to autistic people without an intellectual disability, which we typically define as an IQ below 70. And it's also defined by some functional qualifications. So let's think now about old age and autism, midlife and old age. So I don't know who here in the room knows this, but I think something that's really interesting when we think about this is that the first person ever diagnosed with autism Donald Triplett, who's in this picture right here, is 85 years old, and he lives independently currently in Mississippi, which is in the town that he grew up in his community, and he worked for many years at a bank. Because the first person ever diagnosed with autism is only now in old age, this means that we're really now just beginning to be able to learn about what happens to autistic people as they get older. We've heard for many years from families, and we have studied to some degree that people on the autism spectrum may have greater morbidity or more health problems throughout their lives and may die earlier. And that's specific to the current generation of middle-aged and older adults, not necessarily the current generation where diagnostic services and treatments have increased over the lifespan, and they may have a different experience with supports throughout life. However, we have really limited information and research on why and how health conditions develop, and that limits our ability to prevent health conditions from developing. And for me, what's important is that we're treating health problems that make life harder for autistic people. We're not treating autism. So we're not trying to change autism, we're trying to change the things that make life harder for autistic people and for all of us in the general population. So we view this to a degree from a health disparities lens. So health disparities are inequalities in health that can be that are unjust and should be preventable. So we see in autism that we have more health problems in autistic people at all ages, from early childhood through old age. And then I'll talk about some of our new research on aging and autism. We also know that autistic people have sensory and communicative differences. So they experience the world differently and they communicate with others in the world differently. Lead to challenges access to healthcare, both because of limited physicians who will see pediatricians who have training in developmental behavior pediatrics who are trained to work with people with developmental disabilities. Providers aren't trained in the same way to work with adults, and especially older adults. We also may be seeing that healthcare providers discriminate against people with developmental disabilities and autism, and that in the same way, there is an overshadowing of actual health problems by physicians assuming that they should be treating autism symptoms, behaviors, not health. So right now, we know a couple of things. So we know that there are more adults with an autism diagnosis than ever before. Each year, about 50,000 people with autism reach the age of 18 and become adults. We know that autistic people have health problems throughout their lives. And that, I think, specific to the reason I'm presenting today, people with intellectual disabilities who don't have autism also have more health problems throughout their lives than people who don't have intellectual disabilities. We don't know a couple of things. So we don't know what are the common health problems in midlife and beyond in autism. We don't know whether intellectual disability is driving health problems in autism or whether this is something that's inherent to autism. And then we also don't know how we should help. And what we can do to help people on the autism spectrum live long, healthy, and self-disease. Today I'll be talking about these two factors. So I'll be talking specifically, let me see if I can get this to work, about common health problems in midlife and beyond, and then the impact of intellectual disability. And I'll give a couple of tips at the end for things that may be helpful when you're interfacing with providers. So the first study I'm going to talk about, I completed while I was in the Waisman postdoc with colleagues from the Waisman Center. So the big picture of this study is that our goals were to identify health problems that would distinguish people who have died. So this was a study of people who had died at the Marshfield Clinic compared to a group of community members who had also died. And we wanted to use a data-driven approach to help figure out differences based on their electronic health records. The major finding of this study is that we were able to find that autistic people do have very, very different patterns of health problems. And I'll talk a little bit more about that in a little bit. So we had a very unique data set that allowed us to delve into whether we can find patterns of diagnoses that distinguish people with autism from community controls before their deaths. So the Marshfield Clinic is a large practice in northern, central, and western Wisconsin that serves about 97% of the population area. People don't move from this area either. So we also find that we can look at a really large portion of people's lives since 1979 in many cases. We had data on 91 people with autism who had died, and then we matched them to a bit over 6,000 community members who had also died. And we wanted to see what patterns might distinguish people with autism from community members in their electronic health records. So the key to interpreting this is that these are not the most common things. These are the things that distinguish people the most, that differentiated autistic people from community members the most. So I think, as we would expect, we saw things like that people on the autism spectrum used medications in the long term. They had epilepsy, they had developmental problems. I think, interestingly, something that we found is that we saw really high prevalence and a very distinguishing pattern of problems with cardiovascular disease and motor function. We also saw lots of codes in their electronic health records that might indicate that they were going to the doctor was just running some tests without a real reason for them. So they were non-specific, which might indicate an underlying health disparity because people were not being tested for specific things. They were just being given a test because that's what the doctor felt that they had to do. We also found lower prevalence of cancer, and I think that this is important to think about in terms of we found that they were diagnosed less with cancer, not that they had cancer less. So it could be that autistic people have cancer at higher rates, but it's just not being diagnosed. So these are just what was in their electronic health record. So, and able to use very high quality data. We had on average about 17 years worth of health record data for each of our participants. And it's the largest sample of autistic people before their deaths ever studied, and the first study to look at lifetime patterns of health problems. This tells us that autistic adults may either be diagnosed differently by providers or that they may have truly different patterns of health problems. So it might be a difference in diagnosis and providers that might be a difference in underlying health problems in autistic people. The limitations of this study are that this sample of people, so they died between 1979 and 2016. So it could be that this group of people is really different from the current generation of middle-aged and older adults. We also didn't have great and reliable data on their intellectual disability because their psychiatric records were kept separately from their medical records, so we couldn't look at psychiatric records for intellectual disability. So to truly test whether this is something that is related to autism or something that's truly just driven by intellectual disability, we needed to use a different technique in a different study. Which gets me to the second study that I'll talk about. So we looked at, this study was accepted recently and should come out within the next month or so, looking at the health of specifically middle-aged and older adults on the autism spectrum who were Medicaid beneficiaries in Wisconsin. I did this in collaboration with my colleague, Eric Rubenstein. So why might intellectual disability be important in autism research? So, we do know that people with intellectual disability are in many cases systematically excluded from autism research. We've done a really bad job as a field at including people who have an autism diagnosis and an intellectual disability. We know in intellectual disability, as I mentioned earlier, that there's a really well-established high prevalence of more health problems in intellectual disability. And something that I think is interesting as we're trying to parse health problems and how they emerge at the end of life is whether what we're looking at in autism is really genetic subgroups that are driving these increased health problems later in life that are at this point yet unknown. So, and it could be that intellectual disability might be a marker of a genetic subtype that could be associated with more health problems in mid to late life. And then we also know that historically and currently, people with intellectual disability and people without intellectual disability receive different levels of support from our public social service system, but also from their families and communities. So there could be some real social differences that could be underlying differences in health problems. So Medicaid. Medicaid is most of you probably know what Medicaid is, but I'll do a bit of an intro for people who might not know about it. So it's a state-administered anti-poverty program. So states get money from the federal government and then use some of their money to fund the programs. And it provides free or low-cost health insurance to people who are low income or who have disabilities. So if you have an autism spectrum disorder diagnosis in adulthood, it's different, qualifications different in childhood, but in adulthood you have to both diagnostic, functioning, and income requirements. So this group of people would have to have assets below a certain level, so they would be what we would typically think of in the research world as lower income. And this provider of healthcare is really, really important for people with intellectual and developmental disabilities. And we think about policy right now, we should also be thinking about the impact of cuts to Medicaid on people with disabilities. So I think that that's important as an advocacy topic. So the big picture of this study was that we were trying to describe the physical and mental health of middle-aged and older Wisconsin Medicaid beneficiaries who had a diagnostic code for autism spectrum disorder during our study period. And using these data, our goal was to test differences in the physical and mental health of autistic people with and without intellectual disability. For us, this is the first step in describing the physical and mental health problems that adults with autism have in their Medicaid claims during the study period. This builds upon the previous study by dealing with some of the limitations of our sample, being a primarily geographically located sample, and it also allows us to really specifically test the impact of intellectual disability in autistic people. So this study, which has 143 autistic people in it, is the largest study of middle-aged and older adults with autism published to date. So it'll be the first study of health problems, the largest study of middle-aged and older adults with autism. As we would expect, the sample was mostly male. I think something I want to really highlight here is that although our sample was mostly white, we did have a bit over 80% of people in our sample who were non-white, which tells us that we are actually getting at a group of people that has been systematically excluded from developmental disabilities. And importantly, less than half had an intellectual disability. So we had a really good group in which mental health problems. So a different slide set loaded, but so the bottom bar here is, so the bottom bar is people with intellectual disability, and the top bar is people, let me see if I can get this to work. So, okay, so in the top bar is people who don't have an intellectual disability. So intellectual disability, no intellectual disability. So the key to our study is that we didn't find any group differences between autistic people with and without intellectual disability in any of our larger groups of physical and mental health problems. When we think about actual prevalence of these health problems in autism compared to the general population, even though we didn't include people in the general population in this study, we do see that prevalence of health problems is higher in some cases. So as an example, cardiovascular disease, which is abbreviated as CVD, about 49% of our sample of autistic adults had cardiovascular disease in their mid-50s. In the general population, we would expect that number to be about 37%. So we are seeing that prevalence of health problems is higher, but that we aren't seeing any differences that are being driven by intellectual disability. And this study does, in some ways, replicate the previous study. So we found very similar prevalence of many of these health conditions in this second sample in midlife and old age in autism. And the key is that it suggests that there may be something about the lived experience of being autistic or a yet to be determined genetic factor that may be driving high prevalence of health problems and autism, regardless of whether people have an intellectual disability. The way that we have been thinking about this in my research, more health problems in autistic, so they may begin as much as in my lab. We're working on some studies to try to understand why this is happening so that we can develop ways to prevent it from happening. So I have some preliminary implications that are based on the good information that we have in the general clinical work with autistic people and some feedback that we've gotten from autistic self-advocates about things when they're interfacing with the healthcare system. So we know that services and supports throughout life are really necessary. So all of us need some support to do well in our daily lives. It may be that some people on the autism spectrum need more or less supports to thrive in their daily lives, but we need to do a better job of including people and supporting them throughout their lives. So we need to be working on social inclusion, we need to support families, we need to help people transition from different independent living environments, so the transition from living with families to independent living when parents get older, and then potentially to moving to a nursing home near the end of life when somebody may require more complex care. So we need to work on supporting people in those transitions throughout life. We need to be making sure that we're doing things to improve health throughout life. So we're doing preventive and routine care for autistic people, just like we would be for all. We need to support people being active and making healthy choices, both in their communities and then for people who live in group home settings or institutional settings. And then it's also possible, and what I'm beginning to think we might be finding is that we may need to be doing some disability-specific specialty care. So that may be related to aging earlier, developing health problems earlier, such as doing earlier screenings for health problems with physicians, maybe 10 to 20 years earlier, like we would for some other people with developmental disabilities like Down syndrome, who we would screen for dementia earlier than we would people in the general population. What you can do as individuals and family members and clinicians who care deeply about somebody with autism is that you can make sure that you have correct permissions on file, so a medical power of attorney to help to make some decisions about what will happen if you can no longer make decisions for yourself, and who will be the person who will be able to make those decisions. If you or the person who you care about has mental health problems, it may be necessary to also have a mental health power of attorney to make decisions when you're unable to because of mental health problems. And then, like all of us, we should have an advance directive or a living will. So making decisions early and collaboratively about what we want to happen to us at the end of our lives. And then, in addition, it's important to have permissions on file with physicians to be able to access medical records. This may be something that'll need to be renewed every year, but it's something that you want to make sure that you're collaboratively talking with physicians about as the person who you care about needs more complex and greater intensity of healthcare as they age. So I did a quick and dirty survey on Twitter of some #ActuallyAutistic advocates who gave me some really good information about what they wish people would know and what they wish physicians would know about preventive care. So we got to know what preventive care we need at all ages and make sure that we're advocating for it. Physicians may not be giving people the preventive care they need, so it's important to make sure that you're being a good advocate for yourself or the person you love or the people you work with in your clinical work. It's important to also request accommodations to help you succeed from a communicative standpoint, and also to deal with any sensory challenges or differences that you may experience. So asking for things like going to a room earlier be helpful, asking for the lights to be turned down, asking for noises to be turned off on machines. These are all things that providers should accommodate, but they don't know to accommodate unless it's specifically asked for. And then in the same vein as the sensory challenges, it may be that autistic people experience pain differently, so they may experience more or less pain sensitivity. Know that that just may be different, and it may be something that you need to educate people about. And then I think one of the keys is that we don't want providers to inappropriately place emphasis on behavior and autism symptoms when they should be placing emphasis on health and well-being. And it may be the case that changes in behavior or mood in an autistic may be indicative of a medical problem and not of autism. The key is to know yourself and to be your best advocate and surround yourself with people who can help you advocate for yourself. So, and what are we doing in my group to try to move this forward? So we're expanding our research using larger data sets, very big data sets of tens of thousands of people using both Wisconsin Medicaid and a national 100% Medicare data set, which it provides health insurance to older adults and people with disabilities. We're also beginning a new study this spring where we're going to be talking to people on the autism spectrum and their family members or the people who help them with their health care about health and health service utilization in middle-aged and older adults with autism. The goal of this is to eventually develop a patient navigation intervention and to then be able to train healthcare providers to work with older adults with autism, perhaps even geriatricians who get a little bit more training than standard physicians. So, and I also want to acknowledge my mentors and peer collaborators, and then my team, the Aging and Health Equity and Developmental Disabilities team here at the Center, as well as the funding we've received. For this study, it's really important to emphasize that we also use data from the Marshfield Clinic, which has a really helpful partnership with the Wilson Center that we want to be able to acknowledge and thank. So, and I'm happy to take, and thanks so much for coming.
Hi, I was wondering, research has done anything in way of investigating the factor of like stress on these individuals and how that might be increased prevalence of health conditions?
Yeah, so I have a body of research that has actually looked at stress, and I became interested in health through my research on stress. So in my research, we found that autistic people report stress. They don't necessarily in adulthood, especially as they get to middle age, experience stress differently at a biological level. And also found that stress is related with quality of life and health. So some of the interventions that we're working on developing are stress reduction interventions that would also help people navigate healthcare systems. So I think stress is really key, and it might be one of the factors underlying the really high prevalence of cardiovascular disease that we're seeing.
I wondered if there's a kind of legal form that's newly available because of the HIPAA. What we find is we can't make appointments for our sons. We can't really get any information in the same room and him saying, yes, you can talk to my mom. So I don't know if that's available, to put into a medical folder, or if you have any information about that.
Yeah, so based on my best knowledge, which isn't totally complete on this, I don't believe that there is a single form that can make it so that you have access indefinitely, unless you're a guardian, right? Which, and I think there are mixed feelings about guardian. People have different lived experiences of guardianship. So I do know that with the electronic health record, you can request access so if you have Epic which is Epic's electronic health record system, at the physician's office where you see a physician, or at the hospital system you typically use, there is a way that you can request proxy access through the electronic health record, and that way you can actually see the doctor's notes and you can schedule appointments through their electronic health record. So there may be, even though there isn't a really great legal way to do it, a way to sort of circumvent it through new technology with the electronic health record system. And I know that at Epic they're actually working on improving that specifically for families of people with developmental disabilities or who have other special health care needs. My husband works at Epic, so and he's on the team who's kind of working on improving the accessibility of Epic for people with developmental disabilities. So I think it's coming, and I think that the way through it is maybe through the EHR until we change legal models.
So you made mention earlier that we need to learn to get doctors to stop focusing on the actual autism and the behaviors and more focus on the health conditions. How do you recommend doing that? Especially since they can't communicate for themselves.
Yeah, so it's really hard, right? So the long answer, it'll take longer, is that we need to change physician training so that physicians are trained to better accommodate autistic people and people with other developmental disabilities. They have the right supports in place. They know that people aren't just their behaviors. Pediatricians get that training. Family medicine doctors, internal medicine doctors, geriatricians don't get any training on developmental disabilities, with the exception of maybe like one class in medical school. From a practical perspective, for somebody who's in a physician's office trying to help, I think that the key at this point is advocacy. So advocacy on the part of the emergency contact or loved one or helper who's in the room with the person, or advocacy from the autistic adult. I also, if your physician's office has a social worker on staff, at least in Madison, we train in our MSW program about half of our students specifically on developmental disabilities. I teach a course on developmental disabilities. And one of the things we work on is advocacy in healthcare settings. So I think that's another way to do it. So it's really just good advocacy skills. I wish we had a better answer from a societal perspective, and that society was doing a better job of making this easier for people. But I think right now, advocacy is really key.
Any other questions?
Mm-hmm.
Lauren, before responding, can you just reframe the question for our online viewers?
Yeah, so the question was about the woman who asked the question's granddaughter, who is in an employment setting that's really great and supportive, but where there are issues with high levels of stress even in a supportive work environment, and given our push as a society for people to work, right? So I think it's a hard question, and I think that when you think about healthcare in our society, it's really a catch-22, because you either need to be able to qualify for healthcare through Medicaid and Medicare, or you need to have a job that pays well enough and that has good enough benefits that covers healthcare well. So private insurance varies in how good it is. Purchasing insurance can be really costly. So working, I think, is this really difficult thing where you want to make sure that you can work, because work gives us meaning in a lot of cases, and it's expected by society, and it's something that we value as a society, but it can be very stressful and difficult. And I think it's a really hard question, because the way that society expects us to be isn't always aligned with what we should be doing or what would be best for us, right? And society doesn't always support people to work in ways that reduce their stress. So So it's something we have to work on. I don't have a fix right now, but it's something that I'd like to see change over time.
Just so we can keep on time, I think we'll end questions for Lauren. Thank you so much.